All right, we should go ahead and start at precisely 1 p.m. Eastern Time, 12 p.m. here in Houston, Texas. I'm AJ Marion, and I'm most delighted and honored to host Dr. Roberto Bolli along with the IACS team. Indeed, this is our inaugural webinar of the International Academy of Cardiovascular Sciences. The Academy really is an educational program that is a nonprofit independent organization fully committed and dedicated to advanced cardiovascular sciences throughout the world. We have the distinct pleasure of having Professor DK Devendra Agrawal, who is the secretary, and every person of the IACS basically. Agrawal, DK, if you wish to say a couple of words, if you're more than welcome to introduce the Academy to this audience.
So thank you very much, Professor Marion. Give me an opportunity. I welcome all participants in this inaugural webinar session. This is a new initiative under the directorship of Professor Marion, which we wanted to start to enhance the cardiovascular research, training, and mentoring, especially to our young generation. And we are blessed to have Professor Bolli as our inaugural speakers into this on a very relevant topic to research in cardiovascular. As Professor Marion said, that our goal in the IACS is to really enhance the education, training, and research, and then promote the career of young generation at every stage. So with this, I welcome you all again and invite you to attend all these, and as well as attend our annual meetings. The next coming meeting is coming in Las Vegas under the chairship of Professor Buddha Don. Thank you, AJ.
Thank you. Thank you, DK. Grateful to you and the IACS for sponsoring this educational program. With that, now the highlight of today is my distinct pleasure and great honor to introduce our inaugural webinar speaker, Dr. Roberto Bolli, who has been the president of IACS, and therefore this is really enormous gratitude and appreciation to Dr. Bolli for his leadership. Dr. Bolli is an eminent physician scientist, a pioneer in molecular studies of cardioprotection, stunning, and world undisputed leader in cell therapy for heart failure. Dr. Bolli has made a number of seminal contributions to our knowledge in the field of preconditioning and stem cell and stunning. He delineated a number of signaling pathways, including role of NOS and role of PKC and several other signaling pathway in cardioprotection. He pioneered the field of cell therapy for heart failure a couple of decades ago. His clinical trial named Scipio, very astutely named after that Roman statesman and general. Scipio is a now landmark study with over 1,700 citations. Briefly, to give you a background on Dr. Bolli, he attended the University of Perugia, where he received his MD in 1976. And interestingly, several decades later, he received Perugian in the World Award for his being the eminent leader from his alma mater. Then after his training as an MD, he attended NIH for fellowship and then joined Baylor College of Medicine, initially as a fellow to train in clinical cardiology and subsequently faculty, where he rose the rank of academia to full professor. And that's where I had the distinct pleasure of knowing Dr. Bolli and admiring his exquisite research programs with meticulously designed studies. Then it was in 1994 that he was recruited to University of Louisville to lead the Department of Cardiovascular Sciences, and also became the director of Institute of Molecular Cardiology and vice chair of research at the Department of Medicine at the University of Louisville. He currently is professor of medicine and physiology and distinguished university scholar. And this is the fascinating part of it. He has also Legacy Foundation Kentuckiana, Kentuckiana distinguished chair in cardiology, which is really a community-based program that admire leaders in Louisville for their accomplishment in the community. And he's, as mentioned, director of Institute of Molecular Cardiology. In terms of his research program, as I indicated, he initiated research on myocardial stunning and reperfusion injury and ischemic preconditioning, and identified a number of key molecular pathways in that. And then most recently, the last 2 decades, he has focused on adult stem cell for treatment heart failure and pioneered several clinical trials that we will hear about some of them today. Dr. Bolli has published his discoveries in over 500 publications, which have collectively received close to 70,000 citations, and has, in terms of metrics, is in top 0.1 percentile, which is the score that he typically receives for his R01 grants, and anything less than top 0.1 percentile is not acceptable to Dr. Bolli. For his contribution, he has, NIH has given him the Merit Award and has funded his research for over 40 years through both R01 U programs as well as program projects, large grants. One of his most, in my opinion, remarkable contributions to cardiovascular sciences was his leadership in circulation research as a really the legendary editor, I would say, that really transformed the circulation research to be the most prominent cardiovascular journal during his tenure as the editor-in-chief, and initiated a number of initiatives at Circ Research, which the current editor currently have decided to pursue, including profiling the young investigators and also doing compendium, which seems to be exceedingly popular and is still being continued, and many other initiatives that put the journal at the top and also doubled the impact factor of the journal during his tenure. Dr. Bolli is currently editor-in-chief of Molecular Cellular Biochemistry and also serves in various editorial activities for other journals. In addition to, it really serves the scientific community devoted in a selfless manner, and he serves as AHA as well as at NIH various programs, and was the past president of IACS as well as past president of IHSR, and as well as Basic Science Council of College of American Heart Association. For his contributions, Dr. Bolli has received numerous awards, too numerous to mention. I will just mention that he has received a Merit Award from NIH. He has received, he was inducted to American Society of Clinical Investigation very early in his career in 1991. He is the Physician Scientist Award. He is the Distinguished Achievement Award from AHA and Distinguished Scientist Award from AHA, and you name it. Really, he has been well appreciated and recognized by scientific society for his outstanding contribution to the field. I'll read one of them, which is notable from AHA Research Achievement Award, which sums it up very nicely. This was in 2013. This award was given to Dr. Bolli for the profound and lasting impact of his extraordinary contributions to cardiovascular research. With that, we welcome Dr. Bolli, our sincere gratitude and grateful to you for agreeing to give our inaugural webinar of the IACS webinar series. Dr. Bolli, thank you.
Yeah, thank you so much, Professor Marian, for this very flattering introduction. I am humbled. I want to thank you and Professor Agrawal for inviting me to the webinar, and I want to say I'm deeply honored to be the inaugural speaker for the webinar
Dr. Bolli,
series. Yes?
allow me to introduce the panelists that I forgot. We have
Yes.
Jay Zong is on the right side of my panel. Dr. Zong is the chair, Department of Biomedical Engineering and endowed professor at UAB. I have Dr. Buddha Don. He is a professor and chairman of the Department of Internal Medicine and at University of Nevada, Las Vegas, and we'll be hosting the next IACS meeting. Our sincere gratitude to Natalie for organizing this, and he's been very capable, and we truly appreciate what you have done. And you heard from DK, Dr. Agrawal, who is basically runs the IACS, with all due respect to Dr. Dalla. With that, I will shut up now, Dr. Bolli. Podium is yours.
Thank you again, Professor Marian. Thank you to you and Dr. Agrawal for allowing me to be the inaugural speaker of this series. I'm very honored. And I want to say that the Academy of International Academy of Cardiovascular Sciences is a wonderful organization, one that provides many awards for young investigators at all stages, from students to fellows to junior faculty, as well as organizes outstanding meetings in North America, in Europe, and in other continents, meetings that are characterized by a combination of excellent scientific programs and a level of interpersonal interactions and camaraderie and friendliness and warmth that is rarely found in other meetings. So for those of you who are not members of the Academy, I would encourage you to consider joining. The next meeting in North America will be in Las Vegas in September, organized by Professor Don, and I can assure it's going to be an outstanding, superb meeting. And so I hope to see you there. Now, today I have the unenviable task of kind of summarizing one of the most contentious areas in cardiovascular research, which is the use of cell therapy for heart failure. I would say from the outset that I think a lot of the controversy stems from the presence of financial conflicts by some of the players in this field. Let's see, trying to advance the slide. I continue to have no financial conflicts as before. And I would like to give a kind of a brief historical perspective on this area. So this is the classic Gartner hype cycle, which is observed most of the time when a new disruptive therapy or idea challenges the existing paradigms and establishments in medicine. So we have initially a peak of inflated expectations with exaggerated and unreasonable expectations, followed very quickly by a trough of disillusionment when the data do not support the initial expectation. And then there is often a slow recovery towards a plateau of reasonable expectations and productivity based on data. I believe that in cell therapy for heart failure, we are in this third phase of slow recovery, and I'm confident that in a few years we will have a good answer as to the question as to whether cell therapy is indeed useful in heart failure management. I want also to point out that a large reason for that trough of disillusionment has been the fact that in the last 25 years, almost every trial of cell therapy in the heart has involved STEMI patients with ST elevation myocardial infarction. And those trials have been overwhelmingly negative. In fact, it's now well established that cell therapy does not demonstrably improve the outcome of patients with STEMI. Unfortunately, most observers have extrapolated these negative studies from the STEMI patient population to that of chronic heart failure, which is a completely different setting of patients. And in the setting of chronic heart failure, actually, as I'll show you in a second, there are some encouraging trials. So the situation must be we must keep a distinction between STEMI trials and chronic heart failure studies. So as a way of background very quickly, there are two kinds of stem cells. The pluripotent stem cells can differentiate into endo, meso, and ectoderm, essentially in every tissue of the body, and they include two types of cells, the embryonic stem cell, which are isolated from the inner mass of a blastocyst, usually on day 5 of human development, and therefore require the destruction of a human embryo, and induce pluripotent stem cells, which can be obtained from almost every adult tissues. The second type of cells are the multipotent stem cells, which are found in most adult tissues. They are not as able to differentiate as the pluripotent cells. They can differentiate into one, maybe sometimes two tissues. So they have a more limited differentiation potential. And the classic example of them is the hematopoietic stem cell, which is found in the bone marrow and can differentiate only in blood cells. The adult multipotent stem cells are the ones that have been used in almost every trial in cell therapy so far for heart failure. Now, as I said, there are two kinds of pluripotent stem cells, the embryonic and the induced pluripotent stem cells. I personally doubt that the embryonic stem cells or their derivatives, myocytes derived from them, will become a clinical therapy for heart failure. And the reason I'm saying is that there is a formidable list of problems with these cells. First, there are the ethical issues related to the destruction of a human embryo. Secondly, they are very undifferentiated and produce teratomas, which obviously would not be desirable in patients with heart failure. So there is a risk of tumorigenicity. They belong to a different organism and therefore require long-term immunosuppression, which is in itself a disease. There is really not strong evidence that the cells engraft permanently in the heart after transplantation. In fact, in primate studies and other studies, after 2 or 3 months from transplantation, very few of these cells are still alive and present in the heart. And we have no evidence that they persist, let's say, at 12 months after transplantation and therefore regenerate viable myocardium. So the main advantage of these cells, which was claimed to be the regeneration of human myocardium, actually does not occur. Studies in primate have shown a risk of ventricular tachycardia and other arrhythmias. And finally, with the advent of iPSC-derived myocytes, which basically have similar properties to ESC-derived myocytes, the advantages of using embryonic cells are unclear. Now, iPSCs may have a future as a therapy for heart failure. There are several trials, I show them in a little bit, that are testing these cells. One problem has been the cost of producing iPSCs autologously, meaning isolating them from each patient. That's not financially feasible. So now most trials are using allogenic iPSC-derived cells, which may be helpful. The problem is that being allogenic, they may elicit rejection, and there is always the potential for tumorigenicity. So we don't know yet what the role of iPSCs will be. They may become part of therapy, and as I said, there are several trials testing them. At the moment, we don't have any data in humans regarding the role as a therapy for heart failure. So in my judgment, the most likely cells to become a therapy for heart failure in the foreseeable future are adult stem or progenitor cells, particularly mesenchymal stromal cells from various tissues, bone marrow, umbilical cord, or other tissues. Now, I'd like to summarize, kind of look back in the last 25 years. This whole field began at the dawn of the third millennium, around the year 2001. What have we learned in the last 25 years? There has been a lot of learning, a lot of lessons, and a lot of evolution. The field has changed quite dramatically. So at the preclinical level, we have learned that many, but not all, different cell types are beneficial to the injured or failing heart. By beneficial, I mean that they improve left ventricular function in animal models of heart failure, like acute infarction, subacute infarction, chronic infarction. There are literally hundreds of papers showing this, so this can no longer be disputed. It is well established and it's not arguable. Now, the most important advance in the last 25 years is that, contrary to initial ideas, transplanted cells, regardless of which one you use, it doesn't matter whether they're adult or embryonic or iPSCs, do not engraft and do not form new cardiomyocytes. As I said, when we started this 20 years ago, we thought the stem cells would engraft, will differentiate into myocytes and regenerated heart. We now know that is not the case. And I think this has been really the major advance in the field. And because of this, I suggest that the phrase cardiac regeneration should be avoided. I would rather use the phrase cardiac repair because we are not really regenerating myocardium. We are helping the heart to function better, maybe reducing inflammation or other things, but we are not regenerating new muscle. We also have learned that since cells do not engraft, they must work, all cells, including embryonic stem cells, they must work via paracrine or even endocrine mechanism, which means they release several non-coding RNAs, long RNAs, microRNAs, and others, cytokines and growth factors, biolipids, extracellular vesicles, which are then exerting beneficial effects on the surrounding tissue or even on the immune system at a distance. Some cells, like MSCs, have been shown to even donate mitochondria to the adjacent tissue in the heart. The precise nature of this paracrine endocrine mechanism is the million-dollar question. We still are not sure what it is. It will be very difficult to sort it out. The current prevailing hypothesis is that the transplanted cells exert anti-inflammatory actions. That's certainly true for mesenchymal stromal cells, but they've also been shown to perhaps inhibit fibrosis and apoptosis and promote angiogenesis, and they may still have other yet unknown effects. What have we learned at the clinical level in the last 25 years? So first and foremost, administration of adult cells of any type is safe. There has not been one single case of a patient that has received adult cells and has had a major adverse event related to the cell itself. There have been adverse events related to the delivery of cells, for example, perforation of the heart during catheterization, but not to the cell type in itself. So the therapy is clearly safe. As I said, it's not beneficial in STEMI. There will be a whole different lecture, but that's the conclusion of many trials. There are actually promising data with CD34 positive cells in refractory angina, which I don't have time to get into. In the setting of chronic heart failure, which is the topic of this webinar, the mesenchymal stromal cells are currently the most promising cell type that's being tested in clinical trials. And we also learned in the last 10, 20 years that allogenic bone marrow MSCs are superior to autologous bone marrow MSCs, so that basically the use of autologous MSCs has been abandoned in clinical practice. Allogenic, of course, are healthier cells that are obtained from young, vigorous, healthy individuals, so it makes sense that they may be more effective than autologous MSCs. We have learned that in the setting of chronic heart failure, there have been several randomized, double-blind, placebo-controlled phase 2 or even 3 trials which suggest beneficial effects of MSCs at 1 year or longer after treatment, after a single injection. And this beneficial effect has been observed despite the fact that we still don't know much about how to use these cells. We don't know what is the optimal cell type, or the optimal dose, the optimal route of administration, whether it's intravenous, intracoronary, transendocardial, the number and frequency of administration. So we still don't know much about how to use this therapy. And in my mind, it's actually encouraging that despite our ignorance about all of these issues, we have seen a signal for efficacy with cell therapy. Now, I'd like to summarize a couple of studies that, as I mentioned earlier, are encouraging in terms of suggesting beneficial effects of cell therapy in heart failure. CONCERT-HF trial was published a few years ago, was sponsored by the NIH, by the Cardiovascular Cell Therapy Research Network. 125 patients with ischemic cardiomyopathy, average ejection fraction was 29%. They were randomized to 4 groups, either bone marrow MSCs plus c-KIT positive cells, MSCs alone, CPCs alone, or placebo. And the results, just to make a long story short, using the intention to treat analysis, showed that the heart failure-related major adverse cardiac events, which included death from any cause, or admission for exacerbated heart failure, or exacerbation of heart failure not requiring admission, the prevalence of MACE was dramatically reduced in patients that received the c-KIT positive cells from about 30% to 7% at 1 year. This is 12 months later. And that's the green bar, and the yellow bar is the patients who received both the c-KIT cells and the bone marrow MSCs also had a significant reduction in heart failure MACE after a single injection of a drug, which I think is remarkable. And when we look at the components of MACE, the reduction was driven largely by a very significant decrease in hospitalization for worsening heart failure, as you can see in the middle panel. Now, this is the Cox regression analysis showing again that following these patients even longer than a year, that there is a reduction in MACE in patients receiving CPCs in red or MSCs plus CPCs in blue versus placebo or MSCs alone, and the hazard ratio is around 0.2 or 0.25. There was also an improvement in the quality of life measured by the Minnesota Living with Heart Failure questionnaire at 6 months as well as at 12 months in patients receiving the combination of MSCs and CPCs, which is the yellow bar. So in conclusion, the CONCERT-HF trial suggests that in patients with chronic ischemic heart failure on maximal guideline-driven therapy. Remember, these patients are getting the best possible treatment that we can give nowadays. A single administration of autologous CPCs or MSCs has measurable beneficial effects over the ensuing 12 months, namely a reduction in hospitalization for heart failure with CPCs and an improvement in quality of life with MSCs. Now, interestingly, there were several other endpoints in CONCERT. Neither cell type improved left ventricular function measured by MRI or reduced scar size, which begs the question is how exactly did the cells improve then the clinical outcome? And the short answer is we do not know, but we suspect that these cells act by reducing the systemic inflammatory response, which is associated with chronic heart failure and drives the progression of heart failure in these patients. That remains, again, to be tested. However, I like to point out that these findings are apparently paradoxical in CONCERT-HF, whereby we don't see an improvement in ejection fraction, but we do see a reduction in hospitalization and other adverse events. These results in CONCERT are not unique. In fact, the IACS DCM trial published 8 years ago in the Lancet, 109 patients, again, double-blind, randomized, saw a reduction in heart failure MACE after administration of mesenchymal stromal cells. And the DREAM-HF study, which is the largest conducted to date with 537 patients on the right panel, saw a significant 30% reduction in heart failure MACE and other MACE at 2.5 years after administration of a single dose of mesenchymal, bone marrow mesenchymal stromal cells. So these are the data for DREAM-HF. This was published a couple of years ago in JACC. So looking at the entire group of patients on top, there is a trend, but not a significant reduction in the risk of death, myocardial infarction, or stroke. However, when patients were divided based on whether they were inflamed or not, and inflamed was defined as high sensitivity CRP greater than 2 milligrams per liter, then there is really a significant reduction in the risk of death, myocardial infarction, and stroke, whereas in patients who had HS-CRP greater than 2, there was no significant reduction here on the right side, as you can see. So what this study tells us is that perhaps the patients we should target in chronic heart failure are patients that have evidence of systemic inflammation as measured by high sensitivity CRP. That's a very useful insight that I believe we should follow in future trials. So based on these studies, Dr. Braunwald published an editorial a couple of years ago where he lamented the relative paucity of clinical trials of cell therapy in heart failure and called for increased research effort in this area. And we all hope that these exhortations will be heeded by the funding agencies, because the only way to really answer the question as to whether cell therapy works is by conducting large, well-designed trials. So I'd like to spend a few minutes to describe or summarize our translational journey here at the University of Louisville. So more than 10 years ago, we tried to translate two ideas into clinical cell therapies for heart failure. They were the delivery of cells by the intravenous route rather than intramyocardial, and the use of repeated cell doses instead of a single cell dose. The motivation to do this was that our group was the first one in 2010, so it's now 15 years ago, that discovered that the c-KIT positive cells do not engraft in the heart. This was published in 2014, and you can see in this study in the mouse hearts that were infarcted, they were injected with c-KIT positive cells 2 days after infarction, that 1 month after infarction, the number of cells left as measured by a very sensitive RT-PCR technique, these were male cells in female mice, we found that the number of cells was almost zero. So basically, they had all disappeared, even though function continued to be better in the treated heart than in placebo. So that led us to believe that there must be other mechanisms involved. So we decided that it would be important to test repeated cell doses in heart failure. The rationale being that, as I just showed you, cells do not engraft. Therefore, because cells disappear rapidly, repeated doses may enhance therapeutic actions. Essentially, cells are like other medications. We don't give them just in one dose. We give repeated doses in order to have a sustained effect, and the cells are no different than other pharmacological interventions. Until now, every study of clinical cell therapy has used one dose of cells. We also further posited that it was important to test intravenous delivery of cells in heart failure. And the reason for this was that we know that the progressive deterioration of left ventricular function in heart failure is caused, at least in part, by a persistent systemic, not just cardiac, systemic inflammation that results from the activation of the immune system and causes infiltration of the myocardium by inflammatory cells such as monocytes. A lot of them come from the spleen. There is a cardiosplenic axis. We also know that intravenous infusion of mesenchymal stromal cells exerts systemic anti-inflammatory and immunomodulatory actions. In fact, these cells are used in many diseases outside of cardiovascular medicine, in COVID, in ulcerative colitis, in Crohn's disease, and amyotrophic lateral sclerosis. and the graft versus host disease precisely because they're known to have a very potent anti-inflammatory action. So we conducted, to test these two ideas, we conducted a study in pigs where very quickly we produced a large infarct, 2.5-hour coronary occlusion followed by reperfusion. And then 1 month later, once the infarct was healed, now we have a chronic ischemic cardiomyopathy model. Pigs were randomized to receive either 3 doses of placebo or 1 dose of allogenic bone marrow MSCs, and 2 doses of placebo or 3 doses of allogenic MSCs. You can see there was no reduction in scar size with the administration of cells, so no demonstrable regeneration of the heart. But we did the MRI with gadolinium enhancement to measure cardiac function in these animals. You can see here a very nice scar at the apex of the heart. And what we found was that at the end of the study, in the vehicle-treated pigs, these are 3 doses of placebo, again given intravenously, there was actually a deterioration in the ejection fraction. In the pigs receiving 1 dose of cells, there was basically a slight improvement, but the greatest improvement was observed here on the right side in pigs receiving 3 doses of stem cells. Again, these are given intravenously. So to make a long story short, the change in ejection fraction is shown on the right panel. In the control pigs, there was a deterioration at the end of the study. Single dose, no change. In the 3 doses, there was a significant improvement in ejection fraction. We also did the cardiac catheterization to assess load-independent parameters of ventricular function, such as end-systolic elastance, which is the gold standard to measure ventricular function and is rarely measured nowadays. So you can see, if you look at the elastance, end-systolic elastance is the slope of the end-systolic pressure volume curves. You can see at the top on the left side in vehicle-treated pigs, the slope of these curves at the end in red is shallower than at the beginning of the study, meaning that the function has deteriorated. Whereas on the right panel here on the right side, the red slope is steeper than the blue, meaning that the elastance has increased at the end of the study versus baseline. So the quantitative data on the right lower panel show again no significant change in elastance in control or a single dose of cells, but a significant improvement in pigs receiving 3 doses. We also saw a decrease in collagen content with 3 doses of cells, but not with 1 dose of cells, and a decrease in myocyte hypertrophy in the non-ischemic and border regions. So the conclusions of this study is that in this pig model of chronic ischemic cardiomyopathy, the intravenous infusion of either 1 or 3 doses of allogenic bone marrow-derived MSCs improves left ventricular systolic function assessed by 3 independent methods. I didn't have time to show the echo data, MRI, echo, and hemodynamic studies. These salubrious effects of MSCs are more pronounced after 3 doses than after 1 dose, which supports a cumulative effect of repeated doses similar to studies that were done in rats and even mice. And finally, 3 doses of MSCs, but not 1, resulted in decreased fibrosis and hypertrophy in the non-infected region. Taken together, these results demonstrate that intravenous infusion of MSCs are beneficial and have cumulative effects. This again is intravenous, not intramyocardial. And these results provide a rationale for testing the efficacy of repeated intravenous infusions of MSCs in patients with ischemic heart failure, which led us to conduct the KETO trial. The KETO trial is a translation of all this basic work the last 10 years to the clinical arena. It's the culmination of a very long translational journey that started in mice and now is in patients. The purpose of the KETO trial is to test in humans the 2 strategies that we have found to be effective in our preclinical studies, the intravenous delivery of cells and the use of repeated cell dose. By the way, the only way to give repeated cell dose is to give them intravenously. It's practically not possible to give repeated doses of stem cells by intramyocardial injection. It's just too invasive and very difficult to obtain either patient agreement or regulatory approval. So if you want to give repeated cell doses, they must be given intravenously. So CATO is a phase 2A randomized double-blind placebo-controlled multicenter study of single or repeated intravenous administration of umbilical cord-derived MSCs in patients with ischemic cardiomyopathy. Funded by the Department of Defense, the oversight is really very, very complicated. Department of Defense, the Office of Human Research Oversight, central and local IRBs, the Data Safety Monitoring Board, and of course the FDA. It began almost 2 years ago, and this is the structure of the investigators. So we have a DSMB, a steering committee. We have a data coordinating center and clinical coordinating centers. The clinical centers are 3, Louisville, the University of Miami with Dr. Josh Sher, and Texas Heart Institute with Dr. Emerson Perry. The cell manufacturing facility is at the University of Miami with Dr. Khan, and the MRI core lab is at Hopkins with Dr. Lehman. The primary objective is efficacy, and specifically to answer 2 questions. Are 4 repeated infusions of umbilical cord MSCs superior to placebo? If so, are 4 repeated infusions superior to a single? Do we need to give 4 doses, or can we achieve similar effect with just 1 dose of cells? We also have a number of secondary objectives, including the safety and feasibility of single or repeated IV infusions of umbilical cord cells, which we already know basically they're safe, but nevertheless we're going to test it. And we want also to try to understand how these cells work. So we are going to look at the effect of an intravenous infusion of these cells on immune cells in the blood by flow cytometry, and as well as cytokines and chemokines. So this is a summary of the protocol. We randomize patients to 3 groups. The control groups receives 4 injections of placebo 2 months apart. The single dose gets 1 injection of MSCs and 3 injections of placebo. And the repeated doses group receives 4 injections of MSCs, and then patients are followed for 6 months. The primary endpoint is left ventricular ejection fraction measured by MRI. We have a number of secondary endpoints, as you can see here. And we will perform 3 comparisons: 4 doses of MSCs versus placebo, single dose of MSCs versus placebo, and 4 doses of MSCs versus a single dose. And we have power to assess this. We have done our power calculations, and we are confident we can answer these questions. This is just to show you the complexity of this study. Now, I told you we use the umbilical cord MSCs. That's a picture, by the way, of the classical appearance, the cobblestone appearance of mesenchymal stromal cells in vitro. So we did a comparison of umbilical cord and bone marrow human MSCs before we started the trial. So both of them are uniformly positive for CD73, CD90, and CD105, and negative for hematopoietic and immune markers, as you can see. However, when we look at the proliferative capacity, we found that the umbilical cord cells are way superior to the bone marrow adult cells. They have a shorter doubling time, greater EDU positivity, Ki67 positivity, and phosphohistone positivity. And conversely, they show less evidence of senescence, as measured by nuclear size, beta-galactosidase activity, and P21 positivity. So these are healthier cells. They grow like weeds when you grow them in vitro. And in fact, after only 8 days in culture, you get about 8 times as many MSCs from the umbilical cord than you do from the bone marrow. To basically do our studies in 60 patients, we estimate we need only 1 or 2 umbilical cords. Each of them can produce about 4 billion of these cells. So that means you don't need as many passages, and therefore there is less senescence, less opportunity for mutations with these cells. We also did a transcriptomic analysis of the umbilical cord MSCs versus bone marrow MSCs. And we found major differences, and at the top of the list is the inflammatory response genes, which are highly upregulated in the umbilical cord versus the bone marrow, suggesting maybe superior immunomodulatory properties of the umbilical cord versus the bone marrow MSC cells. So KETO is an innovative study because it is testing a new cell product, umbilical cord MSCs, and two new strategies that may change the field of cell therapy, that is intravenous delivery and repeated cell delivery. It is the first study to use umbilical cord MSCs in heart failure in the United States, the first phase 2 study to deliver a cell product by the intravenous route to patients with heart failure, and the first study to examine repeated administrations of a cell product in patients with heart failure. So it is highly innovative. Now, compared with the invasive techniques currently used, which is transendocardial injection, intravenous delivery of cells is simpler, cheaper, safer, and can be performed almost everywhere in almost all patients with heart failure, even as an outpatient procedure, even in rural areas, theoretically. So it is really widely applicable, and importantly, it is suitable for repeated infusions of cells, which in theory could be done several times. Therefore, intravenous delivery could dramatically expand the impact and application of cell therapy for heart failure. If KETO finds that repeated intravenous infusions of MSCs are beneficial in these patients, this would be a paradigm shift or a game changer in cell therapy, because then we would have a new option for treating patients with severe or end-stage heart failure. Now, besides KETO, there are several ongoing trials that are going on all over the world. I summarize them quickly in this slide. In the setting of ischemic cardiomyopathy, the HECTOR trial by Dr. Wu using ESCs, derived myocytes, the LAPIS trial by Dr. Fukuda in Japan, using allogenic iPSC-derived myocytes injected during surgery. Similar study in China by Dr. Yang, again during bypass surgery, injection of iPSC myocytes. And the BioVateChef study by Dr. Zimmermann in Germany, that is using iPSC-derived myocytes, which form epicardial patches or engineered human myocardium, applied on the epicardium of patients with heart failure. There are a couple of studies in non-ischemic cardiomyopathy, the Poseidon DCM2 study that Dr. Harris performing in patients with idiopathic dilated non-ischemic cardiomyopathy, and the SECRET-HF study. It's a phase 1 study by Dr. Menashe in Paris, where he's using extracellular vesicles rather than cells derived from iPSCs in dilated non-ischemic cardiomyopathy. So in the next few years, we will learn about the utility, the possible utility of different cell types, particularly iPSC-derived myocytes, and the use of extracellular vesicles in lieu of cells from the SECRET-HF study. So, as I said, the field of cell therapy is one of the most polarized areas of cardiovascular research. I believe a large part of this polarization stems from the presence of financial conflicts. What is needed to move the field forward is rigorous, well-designed, randomized, double-blind, placebo-controlled trials that conclusively assess the efficacy and finally can answer the question as to whether cell therapy is useful in the treatment of heart failure. In doing so, it is important to have an open mind, to avoid preconceived notions, and to let ourselves be guided by the evidence, not by our own opinions or prejudices or biases, but rather by the evidence, which is the essence of science. Always follow the data. I would like to acknowledge the funding sources of the studies that I have shown you, particularly the Department of Defense, which has enabled us to conduct the KETO trial. the clinical colleagues in Louisville that have helped us, and the research coordinators that have helped us conduct these studies, the basic research colleagues, and particularly Dr. Tang and Xinghui Wu and Li Luo, who are conducting the pig studies and rat studies that have led us to where we are. And finally, most importantly, I would like to thank the Lord for giving me the skills and the opportunities that have enabled me to do everything I have done in my life. Thank you.
Thank you, Dr. Bolli, for this mesmerizing presentation. Your eloquence and your exquisite study designs are really indisputable. And I think if anyone will be able to get this cell therapy to clinical application, it is you. You certainly are the indisputable leader in cell therapy for heart failure. Just to begin the conversation, I see Jay wouldn't let me. Jay says, shut up. He has a question. Jay, I was going to ask a question, but you get the priority, sir. Are you mute?
I think he's muted.
Yeah, congratulations, Dr. Bolli, for the KETO trial, the IV delivery of repeated cord tissue-derived mesenchymal stem cell. That's very important. The finding will guide the future research also. So from the basic science perspective, first of all, this is not a cord blood cell derived mesenchymal stem cell. That's called tissue-derived mesenchymal stem cell. So it's not the earliest study. Many of the study did use the cord blood-derived mesenchymal stem cell.
Yeah, that's correct, Jay. Thank you. First of all, thank you for your comment. Yes, these are isolated from the Wharton jelly, from the tissue of the umbilical cord, not from the blood.
Yeah. So then the cord tissue, from the science perspective, cord has different tissues. So it can have the fibroblasts, can have other tissue, but the people also use the Wharton-derived mesenchymal stem cell. I'm not quite sure the one you used are the Wharton-derived mesenchymal stem cell or the whole cord tissue-derived mesenchymal stem cell. They may be a little different.
Yeah, I believe it's the whole tissue, Jay. Honestly, I need to check with Dr. Khan in Miami. I believe she uses the entire cord. She does not separate the jelly from the rest of the tissues.
And then the mesenchymal stem cell are safe, does not have pluripotent genes. I think you probably have these data showing that these mesenchymal stem cell does not have pluripotent genes such as Fox and these 4 genes that typically in the embryonic stem cell or the iPS cell. So those are the important characteristic of that. And then I was thinking that, again, the congratulations for the KETO cell therapy clinical trial is very important. Then from the study design perspective, you have the doses based on your pig study. That's the foundation. And then it's difficult to do the dose response curve in large animal model. It's easy to do in the rodents. So it's more of those selection, but I missed so you can have a 4 repeated dose, but you have the positive result in the pig study, but we still don't know the optimized dose for that also. That may be if you increase double the dose or triple the dose, you may have even better significant impact.
Yeah, that is true, Jay. I agree with you completely. So we use in pigs 2 million cells per kilogram. The reason we use this dose is that it is in the range that has been used in most human studies of intravenous MSCs in other areas, for example, in COVID, in, as I mentioned, ulcerative colitis or Crohn's disease or amyotrophic lateral sclerosis or graft versus host disease, where generally patients have received between 1 and 2 million cells per kilogram. So we chose that dose in the pig. You're right that we don't know whether that is the best dose, and it's, as you know, it's practically really not feasible to do those responses in pigs. It's too expensive. That is best done in small animal models. And so I guess we are hoping to see a signal of efficacy in keto. If we do, then we should maybe go back to the basic lab and try to figure out if different dosage regimens, either more cells for each injection or more injections, because, by the way, there is no reason to stop at 4. The intravenous infusion, in theory, patients can go to the clinic every, 4 months, 6 months, and get a shot of cells and then go home and go back again 6 months later. So the number of infusions also is not clear.
Thank you.
Thank you, Jay.
Thank you, Jay. Questions from the audience or panelists?
So thank you, Dr. Bolli. It's a wonderful talk that covered a lot of history as well as the future of cell therapy. So I am intrigued by the timing, as we have analyzed studies from the beginning until the current ones, and you thought that perhaps chronic heart failure is a better substrate for cell therapy. Now, I would ask, with regard to timing, if you are going to give multiple doses, would it be appropriate to start sooner after myocardial infarction and the patient follows through with multiple injections in the future? And if you are to take that strategy, how soon would that time point be after a heart attack?
Yeah, that's a good question, Buddha. It's another, basically, we don't have much data to answer that question. So with intravenous, so let me back up. If we were doing transendocardial, as has been done in every trial so far, as you know, it's very hard to convince a patient to come back to the hospital a week or 4 or 5 days or 10 days after infarction and have another cardiac catheterization. So that would not be feasible. With intravenous, that is feasible. So yes, you're right. I mean, in theory, we could give an intravenous infusion, while the patient is in the hospital, while the heart failure is developing. The question is, that many times, and you are a clinician, so you know this very well, many times we don't know whether a myocardial infarction will lead to chronic heart failure, right? Because you measure ejection fraction at 2 days, it's very low, but then by 10 days, it has recovered. That's fairly common, and particularly with medical therapy. So maybe we could see a situation where once, maybe after a couple of weeks, when the left ventricular function, even a couple of weeks, maybe is still improving. But I guess we should start at a time when we know there is chronic heart failure, and then maybe, I don't know, maybe a few weeks after an infarction. And then we know for sure the patient is going to need some kind of treatment because there is a chronic left ventricular dysfunction going on in the patient. So I think the question is when to start depends on when we can be fairly confident that we are looking at a steady state level of ventricular function.
But even if we think about it, the damage is not great, but it is still some damage that can still benefit.
Mm-hmm.
So I'm not sure about the pathology. The division between acute MI and chronic heart failure, the division is artificial. It's a continuous process.
Yeah, you're right. It's a continuous process, and maybe intravenous infusion may be beneficial even in the acute setting. So that's an interesting thought. We have not tested that, Buddha, but I don't know if anybody has given intravenous cells acutely in animal models. But you're right. I mean, they're anti-inflammatory, anti-apoptotic, anti-fibrotic, so they could be beneficial if you give them as a first dose, even in the acute setting. I think, yeah, we need to maybe test that experimentally.
And the other question I have, that you are still using cells. What would be your thoughts on cells versus exosomes that everybody is using now?
Yeah, great question as well. So we don't have, again, data to answer this important question. So my personal opinion is that cells are still better than exosomes for the reason that exosomes are very quickly taken up. Right after you administer them, they're quickly taken up. And so their biological life is not very long after you inject them intravenously. With cells, they presumably survive for a few weeks and they may continue to release their paracrine or endocrine factors for a few weeks after the infusion. So they may have a more prolonged effect. But again, that's my speculation. We don't have any head-to-head comparison. And I guess, Philippe Menachet is trying to answer this question in his study, as I mentioned, Secret HF, where he's giving intravenous exosomes. I believe he's giving 3 doses to patients with dilated non-ischemic cardiomyopathy. So we will, I guess, find out if there is a beneficial effect.
Thank you, Dr. Bolli. Thank you, Dr. Buddha. There's a question from Dr. Sanjeev Dhingra, and he wishes to know, is this going to be a lifelong injection? If there are many dosage, how many doses are enough?
Yeah, that's another great question. I'm so sorry because I keep repeating myself. We don't have data to answer these very important questions, and I guess that's part of being in a new field. So in the pig study, we followed the animals only for 5 weeks after the last intravenous infusion. So we don't know whether the benefits will still be present, let's say 12 months later, right? It's very hard to do it in animals. It's too long of a study. So the keto trial will help us in the sense that we follow patients at 6 months after the last dose of cells. So presumably they will tell us whether cells are still effective 6 months later. And beyond that, again, it will require some trials. The intravenous infusion is fairly easy to do. As I said, it's safe, not very expensive. There is not much of a downside in repeating it, after the first year periodically. But again, we will need some data for that.
Very good. We have a couple of questions online as well. That will be the last 2 questions to address. One is just the gist of it is, what was the rationale for deciding to move from BMMSCs to UCMSCs in your clinical trials? And this, okay, then I'll repeat the second question later, or say the second.
Yeah, so the rationale, AJ, was that, as I showed you some data there, we compared the bone marrow, allogenic bone marrow MSCs with umbilical cord MSCs. The bone marrow, by the way, was a young donor, so this was a healthy donor. And, and we found that there was more proliferation with the umbilical cord, there was less senescence. You need many fewer passages in order to get the billion number of cells that you need, and therefore less chance for mutations and also less expense because cells grew much faster. And then we saw the transcriptomic analysis suggesting maybe a greater immunomodulatory effect of umbilical cord cells. there have been studies also of umbilical cord in other tissues and organs, which suggest they're very efficacious. So we decided to use umbilical cord for these reasons, based on this data, basically.
All right. Again, the same person, Merlin Rajesh, asks the question again. The functionality and viability of UCMSCs tend to decrease with conventional microcarrier-based expansion culture. Let us know if you have come across it or you have some ideas how to mitigate that decline in functionality.
Yeah, that I'm not familiar with the decline in functionality. I know that Dr. Khan, who isolates these cells in Miami, I believe she does not go beyond the 4 passages. She does phenotypical characterization of the markers, and then she freezes the cells. And they're stored in the freezer until she ships them to us or to other centers in the Keto trial. So I'm not familiar with this concept of a decrease in function with time, at least not within the 4 passages that we are using in Keto.
Well, thank you so much, Dr. Bolli. This is a fascinating way of starting the inaugural webinar for IACS, and our sincere gratitude for leading the webinar series. And indeed, you are indeed indisputable leader in cell therapy for heart failure. Thank you again. Our sincere gratitude to you.
Thank you, Jay. You are too kind to me, and thank you again for giving me
Jay
this
wants to say something. Final closure, Jay.
Yes, I think it's such a great talk and review. I wonder if the society and Dr. Bolli agree to put in the website, allow the community to watch and listen and benefit the field.
Right. Yes, DK and Natalie will let you know that all presentations will be on IACS website and will be available to whoever wishes to watch. And usually that's we get the most audience because a lot of people may not be able, especially in Europe or Southeast Asia or Asia, to watch it during our time. So that will be available. Natalie has organized that, and DK has